chapter, we present nutritional management in patients with left middle cerebral artery infarct. This stroke is actually affect lateral parts of the brain, frontal, parietal, and temporal lobes, causing neurological injury. The stroke progresses to the hemorrhagic transformation as it bleeds into the damaged brain tissue and causing hydrocephalus, which is a fluid build-up, leading to brain swelling, increased pressure, and causing midline shift. This condition causes poor GCS score and require mechanical ventilation, and the oral feeding is not safe, and that cause enteral nutrition via an NG tube is the most viable option for feeding. This case report highlights initiation of early enteral feeding as well feeding adjustment based on patient condition and progress of the disease for recovery and reduced nutrition-related risk with careful monitoring for the critically ill intubated patient in ICU. Patient is 62 years old, Indian gentleman, married and retired, no non-medical illness, occasional smoker and ex-alcoholic drinker, admitted to ICU on May 2025. He is referred to dietitian to review the feeding in ICU. The anthropometry is based on the knee height, which yield calculation of 170 cm. Using this height, weight is estimated at 72 kg, estimated at BMI 25. For biochemical data, the electrolyte level is currently a normal in range. However, albumin is currently low and CRP is high in value more than normal, and the other biochemical data parameters is currently in normal range. Dosing weight is based on 72 kg for the requirement, hence based on Tah et al. Energy requirement for ventilated patient, the energy is calculated and estimated at 1765 kcal, and protein is 72 to 93.6 gram, 1 to 1.3 gram per kg based on Eastern critically ill nutrition guideline. For the clinical history, patient is breathing on ventilator, urine output 80 to 120 cc per hour, GCS score is poor, level 4, as patient is sedated. Patient is currently afebrile with positive balance of IO chart, no GI symptoms reported except for the no bowel open since admission. He is overweight or looking and no wasting reported. Medication involved lactulose and bisacodyl suppository, potassium dihydrogen phosphate injection, sedation IVs such as fentanyl and propofol, metoclopramide, atropine and insulatide, augmentin, pantoprazole, and norepinephrine. For diet history, patient was currently on keep nearby mouth due to the upcoming procedures and will be allowed for feeding post-procedure. As reported by the daughter-in-law, his appetite was well before admission and no weight loss was noted. Patient able to finish his meal and estimated energy is 1000 to 1200 kcal per day with protein 45 to 47 gram per day. So the ND is swallowing difficulty related to mechanical obstruction with its respiratory tube for breathing under ventilator due to the current medical condition, as evidenced by patient is currently intubated and sedated while requiring feeding via RAS tube. Main goals for the intervention is to optimize nutritional status via enteral feeding and prevent nutrition-related complications to facilitate inpatient recovery. Patient is prescribed with nutrient optimum and the feeding will be started via continuous feeding, 24-hour, 10 ml per hour run 24-hour. Total intake is 251 kcal per day, around 10%, and protein is 10.2 gram per day, around 14% of requirement. The first follow-up, patient tolerated well with the nutrient optimum but spike in blood glucose 8 to 12, so the formula is changed to diabetic formula. Glucosanol ready to drink 60 ml per hour, so the total volume will be 1440 ml per day with energy achieved 84% and protein around 64%. New ND is inadequate enteral nutrition infusion. Second follow-up is patient tolerate well with the glucosanol RTD, but since patient is in a palliative care, feeding is switched to powdered formula to reduce the hospitalization cost. So the new regime is glucosanol powder 6.5 scoop plus 200 ml of water. Feeding run 60 ml per hour flush 100 ml per 6 hour. Volume is 1840 ml per day. So the energy achieve 100% and protein around 85%. New ND is inadequate protein energy intake. And then the third follow-up is patient tolerate well with the diabetic powder formula, but spike in sodium level was noted in a trend. So the feeding was changed to Renomet 40 ml per hour with volume of 960 ml per day. So energy able to achieve around 97% and protein around 82%. The ND is enteral nutritional composition inconsistent with needs. To monitor is total intake, which involve parameters such as volume, energy, protein, infusion rate, dilution, and IO chart. And then for the biochemical data, it will be observed the renal function test and blood glucose, and the toleration of the feeding also will be noted, such as gastric residual volume, GRV, bowel open, and GI symptoms. So the learning point from this particular case is the feeding introduction of the early enteral feeding in patient and gradual increase in feeding volume for critically ill intubated patient in ICU, adjustment and changing of enteral formula based on patient current condition, as well how to decide the patient nutritional requirement to monitor tolerance and feeding progress in the critically ill patient which is in ICU. That's all for my presentation. Thank you.